Where's my bloody pen again?
Good afternoon and welcome to West Berkshire Health Scrutiny Committee. I'm Councillor Claire Rolls, Chairman of the committee. I'm supported today by Councillors Alan Macrow as Vice Chairman, other members of the committee in the meeting this afternoon, Councillors Tony Linden, Jeff Brooks and Jeff Beck. Council officers and external parties joining us to advise and support the meeting are Michelle Paley from Elysian Healthcare, welcome. And Joe Sherman, the Hospital Director from Elysian Healthcare. Again, welcome Joe in the room. We are expecting Chris Lowry, who's the Directorate Manager, Berkshire Cancer Centre, Royal Berkshire NHS Foundation Trust, Nicola Costin-Davis, again from Royal Berkshire NHS Foundation Trust, and Dr. Kajal Patel, who is a cancer clinical lead at the CCG. And also expecting to join us, in fact, I can see Tom Broadfoot from Royal Berkshire Foundations Trust, who's just joining us now, and Nicola just zooming in. Welcome, Tom and Nicola. Thank you very much for joining us. And we're also expecting Andrew Sharp, who's the Chief Officer from Health Watch West Berkshire, and Andy Sharp, Executive Director, People at West Berkshire Council, to join us at some point. Vicky Phoenix is the clerk for the meeting. The meeting is also being live streamed via YouTube, and Gordon Oliver is our Zoom host today. Before we start proceedings, I'd like to explain for the benefit of members of the public who may be watching that today's meeting is being held both over Zoom and with councillors present in the meeting room. The meeting is being live streamed on YouTube, so members of the public are able to follow proceedings. During the meeting, I would ask that anyone wishing to speak to raise their Zoom hand, and those who aren't on Zoom just to raise your physical hands. All voting will be done by a show of actual hands. If we hear the evacuation alarm today, we must leave the building immediately via emergency exit. The assembly point is the Dolphin car park. If the lockdown alarm sounds, we will remain seated and await instructions from officers. We will adjourn the meeting until such time as it's safe to proceed. Does anybody have any questions on the formalities before we start the meeting? Okay, thank you. So just moving on to agenda item number 1, apologies for absence. Vicky, do we have any apologies for absence?
Yes, Chairman, we have received apologies from Councillor Andy Moore, and Councillor Brooks is substituting, and also apologies from Belinda Seston.
Thank you. Moving on to agenda item number 2, minutes of the, we've got 2 sets of minutes today, members. The first is the minutes of the meeting held on the 5th of April. Has everybody had a chance to read those? And are there any comments or amendments?
I'll propose acceptance, Chairman.
Sorry, I've got Councillor Bridgman and Councillor Beck. So can I take Councillor Bridgman first?
Thank you, Chairman. I did raise these with officers for the meeting of the 5th of April. I was certainly in attendance on Zoom, and I'm not listed. And Councillor Garth Symptom was present in the meeting and isn't listed. As he was, obviously he's not on the committee, but he was in attendance. So I think both of those need to be reflected in the minutes.
Thank you, Councillor Bridgman. I do recall that Councillor Simpson was attending in the actual room as well. Thank you. Can I just have Councillor Beck? I think was slightly before you, Councillor Brooks. Councillor Beck. You're on mute, Jeff. You're still on mute. Yeah, if you can. We're just trying to unmute you. Councillor Beck, you're still muted. I'm just going to go to Councillor Brooks whilst we sort you out. Councillor Brooks.
I'd like to know if there's a convention, if somebody's on Zoom, they actually are recorded as being in the meeting. They're not frankly in the meeting. So what is the convention for actually recording as somebody attended by Zoom? You can't vote, you can only make an input. What's the convention and why do we need to record that somebody attended by Zoom? Every member of council could attend by Zoom. Should they be recorded?
My understanding, Councillor Brooks, because I actually raised this with the monitoring officer at OSMC, and my understanding is the protocol, and I'm turning to officers just to confirm this, is that actually we do record where that people are physically in the room or on Zoom. That was my understanding of minutes moving forward.
So it will be recorded as on Zoom.
Absolutely, whether you're on
rather
Zoom
than
physically.
present. Yeah.
That's
you.
my understanding. Thank you. Councillor Bridgman.
Yeah, just to Jeff, just to come back to you, I've cleared this one with officers. Certainly, members are in attendance if they are not members of the committee. They're present if they're members of the committee in the room. They're in attendance if they are either members of the committee on Zoom or members of council in the room, and that will be either in attendance physically or in attendance virtually. And there needs to be a clear distinction because of the 6-month rule. You are only counted for the 6-month rule if you are in the room.
Thank you, Councillor Bridgman. Councillor Beck, have we sorted out your sound? No, we still can't hear you, Jeff. Can you unmute yourself on Zoom, Jeff? No. I'm wondering if you should reconnect. Okay, could you possibly, Jeff, we can't hear you, so I don't know what you want to say regarding the minutes. I think, can you put it in the chat perhaps? No. Let me just check if officers can help at all. Can we help with them? No, we can't help on Zoom, Jeff. I'm going to have to move on. Okay. Do I have a proposer for the minutes of the 5th of April? Yes, Councillor Linden. Do I have a seconder? Councillor Macro, thank you very much. Can we have a show of hands, all in favour? Thank you. Okay, I'm going to sign those minutes. Thank you. And then we have another set of minutes to approve, which was the meeting held on the 10th of May, which was purely the election of chairman, vice chairman. Do I have a proposer? Councillor Linden, seconder. Councillor Macro, thank you very much. I will sign those as well. Okay. Moving on to item number 3, declarations of interest. Do we have any declarations of interest, members? Councillor Linden.
Yes, Chairman. I worked for a company on a temporary basis, on a part-time casual basis for MBA Field Marketing, who one of their clients is Alva Media, and this work, paid work, entails placing ads for about a month under clear covers of the nozzles on petrol pumps. And one of the regular ad buyers is Elysian, which owns Thornton Park. So just asking for people to consider working for the company. So that's what I do. And the last time I placed an ad at the pumps was at Sainsbury's petrol station at Calca on Tuesday, 7th of June of this year. So I just declaring the interest, but I don't think it's a pecuniary interest. I've checked with Sarah Clark, who is our senior solicitor and service director of strategy and governance, who's our monitoring officer, and she agreed to that. And I just spoke to her just prior to the meeting.
Thank you very much.
Thank you, Chair.
Thank you very much, Councillor Linden. Any other conflicts, any other interest to declare, members? I just have one, which is my partner rents a flat to an employee at Thornton Park, but I don't have any direct personal pecuniary interest in that. I just thought I'd mention that, and I have covered that with legal, and just thought I'd mention it as under the declarations of interest. Okay, moving on to item number 4, petitions. Vicky, do we have any petitions?
We have not received any in advance of the meeting.
Thank you. So moving on to agenda item 5, I'd like to welcome again Michelle Paley from Elysian Healthcare and Joe Sherman, Hospital Director of Elysian Healthcare, who are with us today in the room. And I'd like to invite Michelle and Joe to present their report on Thornton Park. Thank you. I think we're going to share the report with you. There we go.
Thank you. Yes, just before we start, originally Steve Conway, Operations Director, was going to be joining for the meeting, but unfortunately he had to go to another meeting. So Michelle Paley, who's the Group Director of Nursing for Elysian Healthcare, has kindly agreed to come to the meeting instead. I'm not sure how much you know about Elysian Healthcare, so I thought it would be helpful to do a little bit of an overview of Elysian Healthcare, and which would then bring us on to Thornton Park, and hopefully that will make some sense. Please feel free to ask questions as we go, if that's okay with everybody. So Elysian Healthcare was formed, if I have the next slide, sorry. In 2016, we have an operational board which comprises of the Chief Executive Officer, CFO, we have an Executive Medical Director, Director of Policy and Regulation, Group Director of Nursing, Commercial and Communications Director, HR Director, Legal Director, and then we have Operations Directors that feed into the operational board that come from the registered facilities. Can I have the next slide, please? So as I mentioned earlier, Elysian was formed in 2016. Some of you will be maybe aware that back in 2016, an independent healthcare provider called Priory Healthcare bought another independent healthcare provider called Partnerships in Care. And at that time, the Competitions Merger Authority reviewed the purchase and decided that there were a number of sites that needed to be actually sold off and form another healthcare company. And hence this is how Elysian Healthcare was formed. Initially, back in 2016, in December, there was 21 sites. 10 sites were from Partnerships in Care and 11 were from Priory Healthcare. And at that point, there was a total of 802 service users, and the senior management team of Partnerships in Care took over the senior management of Elysian Healthcare. And then since 2016, the organisation has grown, and in April 2022, we had 73 sites registered with the CQC, 5 sites registered with Wales, and we work with a number of different funders and CCGs and NHS England. And we also have a mixture of hospital sites as well as community supported living. So, and the areas that it covers stretch from the southwest right up to the south coast, across Wales and the northern part of England. So geographically, we're quite a lot. Just really our strategic plan for 2022. There's a number of aims that as an organisation we've identified, and those surround being first choice provider, as well as leading on ensuring service user rights are at the core of everything that we do within our hospital settings and our community homes. Being in a very supportive culture, and also utilising technology to enhance the quality of care that we deliver across all our services. We have a governance structure. Back at the beginning of this year, Elysian was bought by Ramsay Healthcare, who are an Australian healthcare company, and they have a number of sites across Europe, Australia, both mental health sites and also acute medicine. And they bought Elysian at the beginning of this year, And the following slide just shows how our governance structure feeds into Ramsay Healthcare. And we, as I'm sure you probably understand, we have corporate and regional governance structures, which then feed into site governance structures. And there is a two-way feeding process where we feed up and feed back down in terms of sharing of information. Any questions? Okay. Yes.
Oh, sorry, Councillor Linden. Yep.
Yes, so obviously Ramsay Healthcare is regulated by the Commonwealth of Australia or the Federation of Australia. That doesn't affect the structure. So as far as your operations in the UK are governed by the British government, basically.
Yes.
And the Welsh government.
Yeah. So it's CQC, HIW and CIW. The fact that we're owned by Ramsay, whilst we report into them, it doesn't change our governance and our regulatory requirements.
Thank you, Shem.
Next slide, please. Okay, so we have a number of priorities for this year, and many of the objectives are around improving service user involvement at all levels across the organisation, improving our ability to meet the needs of the health economy. We also have a quality improvement programme, and we have a director of quality improvement who is leading on a number of initiatives across the organisation. Next slide, please. So as I said, we have a regional structure, and the operations directors feed into the board of Elysium. So the regional operations director for the south of Elysian Healthcare is a gentleman, Steve Conway, and he is who I report into. So he oversees a number of sites across Wales and the south of England. And that really just, the little diagram there just shows you there's different operations directors covering different areas, geographical areas of Elysium. Next slide. Oh. No. So leading on to Thornford Park.
Good.
Councillor Beck, would you be able to meet? There we go. Thank you.
Okay. So we have a senior management structure here at Thornford Park with myself as the hospital director, and then I have a senior management team that reports into me. That comprises of a deputy hospital director, medical director, a director of nursing, a director of allied health professions, director of sports services, and a HR business partner. So all of those heads oversee different areas of clinical and non-clinical teams and practice across the hospital. Next, just wait a minute.
Sorry, I'm juggling a few things with slides and things. Thank you.
Okay. So a little bit about Thornford Park. I'm sure for some of you who are familiar with the local area, Thornford Park has been in operation for 25 years now. Prior to the Greenman Common departures, it was converted into a hospital, and since then has grown and developed to meet the needs of the health economy. So now we have 143 registered beds, which is 11 wards, and we are a medium low secure service, and also we have 2 psychiatric intensive care units as well. Predominantly our wards are male only, but we have 2 female wards. One is a psychiatric intensive care ward, and one is an integrated female medium secure, low secure learning disability ward. And we are commissioned through NHS England and the CCG. So just moving on to our action plan. So as you're aware, there were a number of requirements. So for Regulation 9, this was around therapeutic activities within the PQs. So this has been reviewed by the Director of Allied Health Professions, and a revised programme is now in place. We are undertaking regular audits to ensure that we're getting service user feedback around their experience, and ensuring that we are delivering activities and therapy that meets the individual needs. Yes.
Apologies, Jem, pick you.
Sorry, it's a psychiatric intensive care unit, which so we will admit people for a very short space of time, around 6 to 8 weeks is normally the length of stay, and it's for people that are in a very acute state but are presenting at high risk to themselves or others, and they can't be managed in a generic acute ward. So once they have been treated for their acute phase, then they'll be transferred back to an acute ward.
Thank you. Councillor Brooks, did you have a question on that?
I do. Are you going to address each of the points in the report one by one? Because the report is very alarming, and I thought it might be helpful, certainly for me and perhaps other members, if you went through each of the points where they had been critical and said how you would remedy those. I think that would be easier to then sort of look at the issues and see what the remedy is.
So what I've done in the presentation is that there were a number of regulation activities that we required to develop an action plan. So the presentation covers the action plan that was submitted to the Care Quality Commission regarding the required actions.
Okay. Can I suggest?
Presumably then they will address, am I muted?
Sorry.
They will address the points in the report that I'm reading, will they?
Those are the required actions that we've been.
Councillor Brooks, may I suggest that we allow the ladies to do their full presentation, and then perhaps we do questions afterwards. I think that probably will make it easier and clearer for everybody. So can we take questions afterwards, and then we can actually allow you to finish your presentation? Thank you.
Yeah, that's really helpful, thank you. But just to clarify, there's a lot of narrative in the report which then translates into required action. So I think the way Joe's put the action plan together, the regulation point is based on the narrative that they've actually put in that very long report. So in fact, it should address all of those issues as we go through, if that makes sense. Yeah.
Thank you.
And so Regulation 9 was around, as I mentioned, around the delivery and the range of therapeutic activities. As I mentioned earlier, this programme has been revised, and we have a revised programme now in place. And we are also undertaking regular audits to ensure that that's embedded and encompasses service user feedback. Next slide. So the next slide was around care records, ensuring that there was patient service user involvement and voice within the care plans, that we were regularly ensuring that our News 2 record keeping was robust. The News 2 is a physical health monitoring tool that is used not only within mental health settings, but also within acute care, and it supports clinicians in deciding next steps in terms of whether having to refer to for medical input or going to hospital. So we've done a number of actions. There was also around emergency equipment audits for one ward, and also ensuring that staff understood and followed the reducing restrictive practice policy. So the reducing restrictive practice policy is around ensuring that we support service users in the least restrictive environment. So that's making sure that we promote and we promote people in their recovery. We ensure that we're not using restrictive measures like preventing people from not taking leave For instance, being restricted by having, I don't know, the garden door shut, for instance. So there was a number of things that the Care Quality Commission felt within the psychiatric intensive care wards that staff needed to understand those areas further. So we have done further coaching sessions and training sessions around care planning, as well as further News 2 coaching. And then what we have followed that up with is regular audits to monitor the quality of the documentation, and then that's fed back through our clinical governance forum. We also have undertaken additional weekly audits of emergency equipment within the one ward that was identified, and that's being monitored by the lead nurse. And we continue to undertake quarterly audits regarding restrictive practice. So we have a restrictive practice working group within the hospital, and we monitor restrictive practice interventions across all wards.
Sorry, can you use your microphone if you just clarity on
could
terms?
you explain what restrictive practice is, please?
Yes, so it means decisions that can be interpreted. So it could be, for instance, a restrictive practice could be that we say that nobody could have a takeaway after 10 o'clock. And that would be a restrictive intervention to service users. So it's making sure that we don't have blanket rules within our hospital, within our wards. So for instance, saying nobody can use the garden at 10 o'clock after 10 o'clock at night, when actually everything should be individually risk assessed.
And I think just expanding on that, it's around showing how we measure risk, because sometimes, as I'm sure you can imagine, in a service like Thornton Park, where we've got psychiatric intensive care, we've got low secure, we've got medium secure, we will have risks and we do have to manage those risks. But it's ensuring that we've actually considered the decision-making process. So if we have made a decision that, you know, for example, in a particular area, we're going to close the laundry door at that point because we've got items in there that people could use to self-harm, but it's how we've actually gone through that decision-making process, and also how we've made sure that service users are part of that decision process and they understand why we're doing it in terms of risk management. Does that make sense?
Thank you.
Next slide, please. Okay. Regulation 18 was around having sufficient staff to facilitate leave for service users within the forensic wards, and also around to ensure that supervision was consistently delivered within the psychiatric intensive care unit wards to staff. So again, we're continuing to monthly audit through hospital clinical governance, and supervision statistics are also monitored through clinical governance, as well as we submit it to our commissioners and stakeholders. So a lot of this data that we're monitoring is not just monitored within the hospital or within the organisation, but also monitored through reporting through to our provider collaborative and other stakeholders as well.
Sorry, Councillor Macri, did you have a question?
Yes,
an urgent question?
It does leave me what I expected to, in the normal sense of the word, that people can leave the hospital.
Yes, so it's about, it's individuals being able to have leave outside of the hospital. Yeah.
Are they accompanied or?
So it'll be individually risk assessed.
Right.
So some will be allowed to have some leave outside of the hospital individually on their own. Some will maybe need 2 staff, some will need 1 staff. It's really dependent on the risk assessment.
Thank you.
Okay, next slide. Okay. Really also just to share with you also the additional governance and audit that we have from our external stakeholders. So not only obviously the Care Quality Commission or our internal governance processes, but we also obviously get audited by NHS England. So we have a quality audit there. We also have quality audits that are undertaken by the provider collaborative. So they're coming into our hospital and monitoring Yeah. So I don't, do people aware of the provider collaborative?
Do you want to expand on that? I think it might be helpful.
Yeah.
It's probably just helpful to explain
Yeah.
how they're an external NHS input.
Yeah.
Okay. So provider collaboratives, when specialised commissioning was moving away directly from it being all commissioned by NHS England, then there was the development of provider collaboratives for different specialised services. And provider collaboratives are made up by both independent sector and NHS groups, if you like. And there's always one lead trust in terms of the provider collaboratives. And the idea is that one of the leading principles is to actually return people to area where possible, so that you haven't got lots of out of area placements. And as I'm sure you can imagine, that's really important in terms of people's recovery and rehabilitation. What's also important is that there's a consistency in terms of assessment, of treatment, of care, of outcomes, etc. So the provider collaborative, we have agreed standards, but they would visit the sites. An example being Thornton, that they would actually be looking at in our quarterly meetings, they'd be looking at our data, but they'd also be coming on site and actually visiting the services as well. So it's just to explain, it's another body that actually comes in.
Thank you.
Okay, and then we have NHS Wales, who will also have the similar governance processes. So not only are we submitting data, as Michelle's just spoken about, they will also come to site and audit our wards as well. And then obviously we continue to have local governance from our CCG, the local authority, and also we have advocacy. So we have a large advocacy presence within the hospital. So we have 2 advocacy providers that are in the hospital weekly and obviously support service users with their voice throughout their care. Next slide. Thanks. So just really some areas of achievement that we feel that we're proud of. And this is really just looking at in our least restricted practice and promoting the ability to enhance access to leave. So there's really just some statistics there which shows you how from 2020 to 2021, we've increased the number of episodes of leave for service users across the years for people accessing leave into the community, our grounds within the hospital, but also having leave to home as well. Next slide. And then some further sort of areas of achievement is our ongoing collaborative working with external stakeholders. So we're very keen to ensure that we meet the needs of the health economy. And that has meant over the last 3 to 4 years, we've worked very closely with NHS England in developing services that meet the needs of the population within the sort of geographical area that we're in. And that has led to the development of specialist services for autism and learning disability, where within our CQC report we had a good rating, and we had mentions of outstanding practice around the development of some of the therapy programs that we have. I think also, to give a bit of context, like any other hospital or healthcare provider, we've also had to manage COVID. And I think that's important to be recognised, that I feel that the team within the hospital has managed COVID very well. We did not have any deaths within the hospital, and we still managed to increase the amount of leave for patients despite us going through COVID. So I think that's a really positive.
Sorry, Councillor Brooks, have you?
To come in, Chairman, when the presentation's up.
Right.
I wasn't sure.
No, I think there's a few more slides, I believe.
Yeah, just one more slide. And then another final slide really is just looking at length of stay. So one of the things that we're really keen, and we work very closely with the provider collaborative and all our external stakeholders around, is reducing the length of stay for people. So being able to ensure that people have the shortest space of time within hospital so that they can actually then be repatriated back out into the community. So there's some data there just really around length of stay and also the discharges that we've had.
And that concludes your presentation. Yes, thank you very much. Can I invite members to raise any questions? Councillor Brooks, could you raise your Zoom hand? And is your camera not working? Right, so if I can just ask everybody to raise their Zoom hands, just enables me to. Councillor Brooks.
Thank you. There are things in this report that are commendable. If I read it right, you didn't have any COVID instances at all from April 2020, is that correct? That's laudable.
Yes.
But there are things in here that are concerning. And I think the nub of it is in your report, page 27 of your report, page 31 of ours. There's 8 bullet points, action the service must take to improve. Are you able to give this commission an assurance that all of those are being taken? I was pretty concerned that care plans seem to be very, very general. It's in the text. And then there are 5 bullet points on should take to improve. I think from my desk, I want some real confidence that you grasp those.
So as I mentioned in the presentation, we've done lots of coaching around care planning and ensuring that the service user voice is within the care plans, and that continues to be monitored, not just by ourselves internally, but also by external stakeholders that I mentioned earlier. So it's the whole action plan that we've just talked about is not only reviewed internally, but it's also reviewed externally by the provider collaborative, where we give regular updates. So there's lots of different assurance processes whereby we have to feed into and provide evidence of how we are moving along with the action plan. And we're also continuing, it's not something you just stop. So coaching and care planning is something that's ongoing. It's not something you just do for a couple of months and then stop. So it's an ever, and the same with News 2 training. That's within our induction. That's with in our regular updates for all staff. So it's an ongoing process. It doesn't just stop. We don't just do a few actions and then we forget about it.
Do you want to ask one further question? And I'll open it up to other members. Councillor Brooks.
I wanted to come back on that.
Yeah, do.
Thank you. That didn't really go to some of these points here. So for instance, can you give us assurance the provider will ensure that emergency equipment audits are put into place? I think there's a sense of yes, yes, yes here, rather than a more generic, we're training and the action plan is evolving and ongoing. Let's get a clear statement from you, I think, that says you're going to take these steps.
Do you want to just give context to about the time frame around this and the steps that you've taken around that? Because obviously this report's from last year.
So this report was from last year. The emergency equipment issue was identified on one ward and it was actioned on that day. When we've subsequently done regular audits, additional audits to what we do to ensure that that hasn't happened again.
So last year I commissioned an audit of all medical emergencies and equipment across all of Elysian Healthcare. I then subsequently have repeated that and checked Thornton Park being part of that, but not the only service, to check that we have medical emergency equipment and checks in place across all services. I did that. I can't give you the exact date, but I think it was April 2022.
Thank you. Can I widen this out to some other members? So Councillor Becks, sorry.
Yes, thank you. The report is a little bit confusing on staff, but it is quite clear to me that there is an over-reliance on agency staff, and the permanent staff are reported to have said that bringing in this agency staff to the extent at which it takes place makes them feel undervalued. And there's also the time it takes to become confident with agency staff. I think we're all aware of the fact that agency staff cost more than permanent staff. So I can't really understand why an organisation like yours has allowed that situation to be as extensive as it seemingly is, because it would seem to be more economical for you to employ permanent staff. Would you like to comment on that, please?
Hi. I mean, I would completely agree with you. We would much rather employ our own staff than use agency staff. Unfortunately, like every other independent sector and NHS services, there are significant shortages of registered nurses across the country. One of the things that we are doing is we have increased our focus on international recruitment. The focus of bringing people on board at Thornton Park. So this week our 400th international nurses just arrived, and we've got a strong focus on getting those people through their OSCE training so that they get registered with the NMC. We've got a significant programme around preceptorship, which is encouraging newly qualified nurses to join us. So we have a dedicated academy where they have ring-fenced training time, and it's really to try and make us a more attractive option for people to be employed by us. I mean, certainly that is definitely what we want to do, as any other hospital provider would want to do. But it is a challenging environment that we work in, and particularly with healthcare workers. I think many of us have been aware, and I talk to colleagues across the industry, that during COVID, it hasn't, you know, we went through a phase where some people came from retail and joined the healthcare market. And then as the COVID situation has eased, people have gone back to retail. But also there's a group of people who found it very challenging to work within a healthcare provision with all of the restrictions and the infection prevention control requirements. And it wasn't necessarily the role for them. So it, you know, it does continue to be a challenging environment. But we have significant focus on it. We have recruitment campaigns. As I say, we run the Preceptorship Academy. We have a dedicated international nurse academy. We have people arriving every 3 to 4 weeks who go through an intensive training programme. We, Thornton Park in particular, run an assistant practitioner programme and a nurse associate programme. And the idea of that is, not only do we have looking at registered nurses, but how do we get those different levels, those different disciplines to support that nursing team? So I think we had, I'm going to say 5, but I might have it wrong. Yep. So we had 5 APs graduate at Thornford in May. Yeah, in May. So that's another part of the nursing team where we've invested in those people who are healthcare support workers. We've invested in their training and their education, and then they've qualified as APs. So there is more to it than obviously employing registered nurses is our goal, but there's more to it, and that is looking at how we get different disciplines in there as well as part of that core nursing team.
Thank you.
Thank you. Presumably that will address this. There's currently at the moment, or there was, insufficient female staff for washing and dressing, etc. Is that been addressed?
So again, we look at skill mix and gender mix when we are allocating to wards. So we have 2 female wards. So the workforce within those wards are predominantly female.
Within a report, it talks about men doing it, you know, which is not necessarily popular with every woman, you know. Thank you anyway.
Thank you, Councillor Beck. Councillor Linden.
Yes, thanks, Chairman. The way I've done things is that we have it in our agenda pack from the inspector's report from the Care Quality Commission. So I'll refer to their pages. So, Chairman, if I'm asking too many questions, please interrupt. There's about 4 or 5 pages I've got some questions on. Starting with page 10 of the report, what people who use the service say. This concerns patients of Hermitage and Bucklebury wards who said they didn't feel safe due to patients assaulting other patients. Has that been dealt with? And has the policing been involved?
Yes, at the time, there was a very difficult relationship between some patients within those particular wards. That has been addressed, and we've worked closely with commissioners to ensure that people get moved on to an alternative placement. Bucklebury ward is an acute admission medium secure ward, so we have a number of patients that will transfer from prison. So we've done a lot of work around ensuring how we can improve the experience for individuals.
So do they still have that fear, or has that been resolved?
That's not what's been reported in our community patient forums.
Thank you. The next one is on governance, which was on page 24 and 25. Staff on wards were not receiving regular supervision, and staff were not aware who their supervisors were or when they were next due supervision. So there wasn't a record of supervisions on the online matrix and not up to date. Has that been sorted out, please?
So yeah, that was particularly for the PQ wards. We were also in the middle of a pandemic, and we also were struggling obviously with staffing, like within any hospital, was it challenging because we had high levels of sickness due to COVID. So there was a reduction in our compliance with supervision, which was shared not just with the Care Quality Commission, but all our other external stakeholders. And that supervision compliance continues to be monitored, because we contractually have to submit supervision data on a monthly basis, and that has improved.
Okay, I've just got two more.
Sorry. A little bit to the supervision piece is that we've undertaken a review of our supervision policy, and we've drawn up much clearer algorithms in terms of how we measure supervision to make sure that we've got clear data, and also how we're recording it, so that it's actually make sure we're hitting all of our staff. And we had a working party across all the sites. Thornton Park actually was part of that group, and we've just rolled out a new way of recording supervision, because we did seem to be having some issues that we weren't capturing all of the data. So we're just piloting that across 8 sites at the moment, just to make sure it really is fit for purpose. But as Just says, we do review that, not just at site, but it comes into people like myself. The last review I did for an NHS data report, Thornton Park certainly wasn't showing as an outlier at all. But we do keep we do a monthly review on that.
Okay, so I've got just 2 more pages, and the last one's very quick. That was on page 29, forensic inpatient or secure wards. So managements of patient risk, they said that was a problem on the Bucklebury ward, didn't always include mitigation plans for identified risks within patients' care records. Has that been sorted out? Again,
that's been addressed through our coaching around care planning. And that's then reviewed through our ward rounds. So the multidisciplinary team review the care plans through the ward round, which we call an ICR.
Okay. So I've already asked a question on Hermitage and Bucklebury wards in terms of safety for patients. Finally, on that page, it's staff follow procedure to minimise risk where they could not easily observe patients. Can they now observe the patients?
Yeah, there was a blind spot that was picked up through the inspection, and we put some additional mirrors in place. That's been addressed.
And the final point was on page 60, requirement notices, action we've told the provider to take, and I presume now that they've all been sorted out. That's all I have, Jim. Is that confirmed, please? Sorry.
That was a yes.
Thank you very much, Jim.
Thank you, Councillor Linden. Councillor Macro.
Thank you, Madam Chairman. I wondered how Thornton Park compares with the other hospitals and sites in the group when it comes to CQC ratings. Is this an outlier, or is this kind of typical?
I wouldn't say it was an outlier. We've got varying types of service, and what we tend to do is we look at the overall rating for a hospital and see where we benchmark them. we do it against each of the CLOEs, against the wards, against the service type, and then against the hospitals. So I think it's important that we dig down rather than taking just the broad rating, but that we also look at it in terms of service line.
So, do you have a further question, Councillor Macron?
Yes, thank you. Something that came out of something you just said on this blind spot. I was a bit surprised really that it took the CQC inspection to actually identify that. So is there not some kind of internal thing you do to make sure this kind of thing doesn't occur?
We do have an annual ligature audit that takes place. The ligature audit was updated by Michelle and colleagues last year. Yeah, do you want?
So yeah, the ligature audit tool.
Yeah,
I mean, it's a good learning point. The audit had been completed at site. The blind spot had been missed. And what I've done is I actually reviewed the ligature risk management policy and procedures and brought in a revised ligature audit tool, which also includes, I don't think we've been strong enough in including blind spots. We were very clear on how we monitor the severity of anchor points, but the blind spot issue that hadn't been as detailed as it could have been. And I don't know if you're aware that the CQC withdrew their ligature management and short briefing guide for inspectors last year, and it hasn't yet been reissued, so that's no longer in the public domain. But there was guidance that came out from CQC in August 2020 about how we manage ligatures, and it was very much it was a briefing letter from Kevin Cleary, and we made a lot of changes around that. However, there's then been a subsequent piece of work going on nationally to look at how there's a consistent approach around ligature management for all services, be they NHS or independent sector, because most people are using a tool that we call the Manchester tool, which is modified in different ways, but there isn't actually a specific national guidance or standard on how you review ligature audits. So that work has been delayed because of COVID. So we were expecting it in 2021, and it's a co-produced piece of work between CQC and the National Forum of Directors of Nursing for Mental Health and Learning Disabilities. And the service user input, NHSE, NHSI input into that. And there's actually the launch event to look at the initial guidance around that takes place on the 24th of June this year. So there will be subsequent review of how we do our policies so that we follow, so that everyone is following national guidance. So there will be a further change happening.
On the issue of anchor points and blind spots, changes we made to the hospital, as say redecoration or refurbishment, I would hope that you actually do an audit immediately after that's taken place as new points might have been introduced.
Yes, so the way we do it is if there are any changes happen in terms of configuration, so that would be decoration, moving things around, a change in a service user profile, say there was an incident.
Have a knife, a fork, I mean.
Councillor Beck, could you just go on mute for 1 minute? Thank you.
So in summary, what I would say is there are trigger points that would cause for the audit to be repeated. That's probably the easiest way to describe it.
Thank you.
Thank you. Councillor Beck, did you have a question? No? Okay. Are there any other questions, members? I just have one quick general question. Obviously, quite a lot of the report was showing requires improvement. I just wondered, as a sort of high-level general point, did this come as a shock to you? Or was some of these areas expected, or you had anticipated? I mean, and obviously, or were you in the process of addressing some of those?
There were some areas that we weren't surprised, but there were some that we actually challenged, and we challenged the report. Particularly around being able to facilitate enough leave for service users. So we did submit further evidence to show that the rating wasn't changed.
Right. Okay. Thank you. Okay, so there's no recommendation associated with this report. So members are simply asked to note the report and consider if they wish to see any further scrutiny work on matters raised in the report included in our future work programme. So perhaps we will come to that towards the end of the agenda. Ladies, thank you very much for joining us today. You're very welcome to stay, but I'm going to be moving on to the next agenda item, but you're obviously welcome to leave as well. Thank you very much. So
Thank you.
thank you. Just moving on to agenda item number 6. Sorry. Oh, right. Okay. So I'm just seeking guidance from officers in terms of just continuing. Yeah. Okay. Councillor Brooks has just left the room shortly, so I'm just going to bring our guests into the room and introduce them. So I'd like to welcome external partners. I believe we have Dr. Kajal Patel to present on the wider cancer priorities of Berkshire West CCG, and also Nicola Constantine Davis to present the report on the current performance of cancer treatment of Royal Berkshire NHS Foundation Trust. So welcome to Nicola and to Dr. Patel. I don't believe, is Chris Lowry?
Hello.
Yes, welcome, Chris. So Chris Lowry is Directorate Manager at Berkshire Cancer Centre, Royal Berkshire NHS Foundation Trust. So I'd like to invite Chris and Nicola to present their report on the current performance of cancer treatment at Royal Berkshire NHS Foundation Trust. So I'd like to...
Okay, so can I just introduce Mark?
Hello, Mark. Welcome.
Yeah, hi there. My name is Mark Folks. I'm a Macmillan Lead Cancer Nurse and Nurse Consultant here at the Royal Berks. And I'll be starting off the presentation with a bit of background, if that suits you. We also have my colleague Catherine Bailey, who's a nurse consultant in breast cancer, who's simply observing from her own education. This whole process is quite interesting, I think, if that's all right with you.
Yes. Thank you very much. Welcome to all.
Okay, so what we're going to talk about today is talk about the cancer services here at the Royal Berks in Reading, and indeed have the coverage of our entire area. You'll see on screen that our mission statement really is to provide high quality, equitable, timely and personalised care utilising latest evidence-based techniques and treatments. We're one of 2 cancer centres in the Thames Valley Cancer Network, or Cancer Alliance as it is now, and it's quite unusual to have 2 reasonably large cancer centres. We have approximately 1,600 new diagnoses of cancer per year. We serve a population of around 750,000. We have close links with tertiary centres for specialist surgery, both locally and in London, Oxford and London. We have 4 main sites for delivering cancer care: Reading, Thatcham, Bracknell and Henley. The radiotherapy is delivered across 4 linear accelerators. We have 2 at Reading and 2 in East Berkshire at Bracknell. Interestingly, our model for delivering chemotherapy is to move care closer to home. So we deliver chemotherapy at Reading, at Bracknell and at the West Berkshire Community Hospital in Thatcham, which is very popular with our patients and something that we've worked hard to do over the years. The other thing I'd like to say is we're relatively informal presenters, so if people want to jump in with questions, then feel free to do so. Just put your hand up. I'm sure the lady chair will do that for us. So cancer access standards, to run through these a little bit. So there's 9 sort of cancer access standards. I'm not going to go into these in great detail because they're reasonably complex, but we have a 2-week wait, which is 14 days to see somebody once they've been urgently referred. And that's shortly to become redundant, to be replaced by a 28-day faster diagnosis standard. So have people diagnosed in 28 days. We have 31 days to start their treatment. Once we made the decision to do so, similar for subsequent treatment. The most testing and difficult of our targets is to treat people within 62 days from initial referral to treatment. That seems like a long time, but in fact, what that what that standard does is put all your diagnostics in the first sort of 4 weeks of that pathway. So basically, you've got to have everybody diagnosed to be successful, really. You've got to have everybody diagnosed by that time. So you've got all your tests, you've got to see the patient, send them to a meeting, specialist meeting, make a decision, and then tell the patient. So it's actually, that's the busiest and most testing part of the pathway. Sort of all of the standards have a degree of tolerance, but and they will vary, but they're quite challenging, particularly the 62-day target. The national ambitions relate very closely to the work that we're trying to do. So there is a national ambition to increase the number of cancers diagnosed at stages 1 and 2. That's to hit 75% by 2028. We're sort of languishing around the 55% currently, so that's quite sort of a demanding target. And in order to do that, there's definite pressure to refer more patients in to us to be assessed for cancer, to see if they've got cancer. The national ambition is to promote and develop rapid diagnostic centres. And here at the Royal Berks, we're the first people to do that in the Thames Valley by doing that in lung cancer. We have a faster diagnosis standard which will become, it's already being measured, but it will replace the 2-week standard completely later this year. We're doing relatively well at that. The other thing that's close to my heart is to develop personalised care for patients. And that's to make sure that every patient who's looked after has at least one, hopefully 2 holistic needs assessment, have a care plan, and that's shared with their GP. And then should I say primary care specifically, will then review the patient and use that information for the good of the patient care. We also have a number of sort of cutting edge tests and treatments, many of which we deliver here at the Royal Berks, including sort of specialised radiotherapy, highly technical radiotherapy, immunotherapy, and there's moves to develop more genomic testing, in some areas proton beam therapy. There's been quite a lot of performance management in cancer care over the years, and that's not going to decrease anytime soon. Okay, so to break that down in a sort of a thematic way, if we look at this slide, you can see how the 62-day pathway, which is the most testing sort of target, works out. So we have GP referral, the person's first seen specialist, 14 days. We treat, hopefully make a decision to treat about halfway through that sort of pathway, and then we've got 31 days to treat the patient. Over the years, we've been relatively successful and actually continue to do so at treating patients once we've made the decision to do that, and we don't reach many patients in that element of the pathway. What is difficult and becoming increasingly so, which Chris will talk about and later on, is the challenges we have in diagnostics, and give more detail of that as we go on. So any questions about this element of the presentation so far? Happy to take them.
I don't think there's any.
Being stunned into silence, perhaps.
Andrew Sharp, welcome. Andrew has a question. I do need to suspend standing orders to take a question. So do I have a? Thank you very much, Councillor Linson, seconded by Councillor Macro. Do we have to vote in favour of that as a group? All in favour? Thank you. Andrew.
Thank you, Chair. And I just wanted to apologise to all the members for my late appearance. I was inadvertently detained in a meeting overran. This is sort of a sort of general question, and perhaps Kajal might be very well placed to ask this, but it always seems to be a sort of conflicting thing between the challenge we have in the UK of early diagnosis rates vis-a-vis European partners, which seem to be higher, and then equally the challenge of residents telling us that, you know, seeing GPs because of the sheer demand and issues with GPs being available is problematic. I wondered if there's any thought process in terms of, are we asking why this diagnosis is happening later in this country as opposed to European partners? You know, is it down to British stoicism of saying I'm fine, or is it access because, you know, currently we know the GPs are under an enormous amount of pressure? Or is it a bit of both? Or I'm just wondering, because we've looked at so many pathways where we've sort of seen there's a blockage here or there, and we've sort of worked, is there a better way around it? Or do we think the 75% target is just a sort of pipe dream, etc.? So it was sort of two-pronged question, if that's okay. Thank you.
I don't know if Kajal wants to take that first, but I'm happy to throw my 10 pence in, if that's all right. So I'll start by saying, yeah, it's a very difficult line to walk. I think the reason why more in the UK we diagnose patients at later stages is quite a large element of stoicism. I think people tolerate quite a lot of poor health before they present. I think there's lots of trouble or lots of difficulty with groups of patients who tend to present later, men being one of them, tend to present later with cancer. The other thing is people who don't speak English as their first language tend to present later. If we look at the data from people who are diagnosed following an admission to hospital, then we'll also see other groups come into that as well. We'll see older people, we'll see patients who are more isolated, and certainly in COVID, there's quite a lot of anecdotal evidence to support the fact that people who are more isolated tend to present with cancer later. So there's a whole gamut of difficulties around diagnosing patients earlier. And I think it's reasonable to try and get more people referred in with sort of a broader array of symptoms, but that does lead to difficulty in diagnosing, because the issue about the pathway is at the first part of the pathway, we've got two groups of patients, people who have got cancer and people who haven't. And we have to treat the people who turn out not to have cancer with exactly the same urgency, or else we fail our targets. So the whole 31-day target, once we made the decision to treat, that's partly why it's easier, because we can concentrate our efforts in, we know those people who've got cancer and we do very well at treating them. When we've got everybody to look after and either prove they haven't got cancer or have, that's a lot more difficult. Does that answer your question?
Thank you. Yeah. Do you want to add something?
Yes, thank you. I think Andrew raises a good point, but I think it's quite complex when you dig into the different layers. As Mark has alluded to, there are different factors that lead to late presentation. And some of those factors include deprivation, language barriers, cultural barriers, which is why we've been doing a lot of work related to that specifically. Also, when you look at screening uptake in different groups, that's different. And awareness of red flags actually is all really important, but it's actually quite complicated. It's important to note that any patient that presents with any kind of what we call red flag symptom, so bleeding from the bottom or an inability to swallow, they would be patients that have access to general practice and would be seen, quickly and be worked up in case they do need to be fast tracked onto a cancer pathway. And one thing I'll cover later in my presentation is that there are some cancers that have very vague symptoms to start off with that can be quite difficult to pinpoint, and some of those vague symptoms can go on before the cancer's really manifested. And that's partly what led to us creating something called a vague symptom pathway, which allows GPs, if you have a patient sitting in front of you that's got vague symptoms, but your gut feeling is that they've potentially got cancer, we can refer them on a suspected cancer of unknown pathway, and they are worked up to look for that cancer in the unknown origin. So there are lots of things that we do have access to. There are lots of things that we try and do within the system to improve awareness of symptoms and increase screening and increase referral on to the secondary care people. But I think Andrew's question is quite complex and there's different layers, and unfortunately with complex different layers you need so many prongs of approach, which is what we're trying to achieve. I hope we can achieve those faster diagnoses and cancers being diagnosed in stage 1 and 2, and I guess time will tell. But again, it's a bit like Mark said, for 100 people that we refer as GPs into the Royal Berkshire system for a suspected cancer, less than 7 of them actually have a cancer. So actually looking at our numbers, the diagnosis rate and the conversion rate is still quite low. Of course, we want to refer potentially everyone that comes with a red flag system, but we do have to think about the fact that we are then going to be subjecting people to CT scans, high dose radiation, going through the pathway, and that 7% of people that do actually have cancer actually need to get through that pathway and get their treatment on time. So it is a complex question, Andrew. Thank you.
Andrew, do you have anything else that you wanted to? Are you happy with the response?
Yeah, I did just want to say it on a positive note that, you know, I've been really impressed with the communications across Berkshire West in terms of reaching out to the groups in terms of screening and prostate cancer. And I wonder whether, you know, one of the things we could look to do with all the health inequalities work is involve public health a bit more in the sort of the awareness side and what have you, because clearly the sort of getting through this stoicism and all the other barriers is something we've got to do, or the targets are going to remain really difficult. It actually being just acceptable to go, I'm worried about this, let's go. And we have so many mixed messages at the moment about, you know, the pressures that things are under. You know, you do get the sort of feeling with some of the older generation that they sort of, you know, I'll just put up with it. And it would be really interesting to see if there's any more could be found out through the data, so we can actually start talking to the population about, honestly, if this is where you're at, you know, do take action, sort of thing. So, but thank you anyway.
Thank you. Councillor Linden.
Thank you, Chairman. I'm very interested to the response, and certainly just a quick comment on Andrew Sharp. I know that Macmillan Cancer Support said there were concerns with the shift to later diagnosis and results of later presentation, longer wait, and I presume that COVID took a share, but obviously I expect somebody to respond to that. But what I'm particularly concerned about is, we know the national picture. How much is there going to be a change with the, not only in this district council area, but also the 750,000 people covered in our area? Because things could be different locally rather than nationally. So I just want people to be aware whether these national concerns are also coming in locally. And also I see a slide for the next one for the cancer pathway, and really why the performance levels have significantly dropped from 82% down to 61.2%. So if somebody could give me an answer when we get onto that, I'll be grateful too, Jem.
Thank you. Do we have a...
So yes, I will absolutely give an answer to that when we get to that slide.
Thank you. Okay, so we'll come back to that.
And Chairman, also that the local differences, I presume, will also be covered as well. Thank you.
Okay. Councillor Brooks, did you have a question?
Thank you, Chairman. The 62 days I get, and forgive me if you covered this while I was briefly out of the room. Is there any correlation between that 62 days and the outcomes? And does it presumably would vary depending on the cancer? So why 62 days? How did we get to that? Is that for outcomes, or would we like to improve it, but that's just our capacity at the moment? As I say, if it's been covered off, forgive me for coming back to it, Chairman, but I think the 62 days is worth looking at, perhaps. Thank you.
Yeah, I can try and answer that, although I don't have all the answers to why it was picked as a 62-day target. But I think back when the cancer access targets were begun, which is sort of like 15 years ago now, I think that the idea was to just bring the whole length of people waiting crashing down. And the best way to do that is to set a line in the sand. I suspect that it was the first month to diagnose a patient and the next month to make sure they were on treatment. So I don't think there was a massive amount of thinking about that. There was certainly quite a lot of public consultation as to what would be an acceptable time. And I think that what I can say is that we do know that the faster you diagnose patients, the faster you diagnose people with cancer, then the more likely they are to survive. There's no doubt about that. So, in fact, what I suppose in an ideal world, we'd like to bring down that 61-day target even further. But in fact, we have, with the current situation we're in terms of particularly in diagnostics, it'll be very tricky to do that. I think there's ways you could improve the time to treatment probably that wouldn't be too testing, but in fact moving the diagnosis sooner will be quite tricky. And the other thing to say about the way access targets work, of course, which you will know working in local council, is the fact that you have the targets themselves should drive change, so they should drive investment. There are a number of issues which Chris will cover later. It doesn't matter how hard you drive sort of recruitment, for example, if there's nobody to recruit. So there are a number of issues around that which we will touch on, but it's a good question, to be honest.
Yes, do.
Thank you. I'm glad it's a good question, but I wonder if we would treat different cancers at a different speed. So from the decision to treat made on your diagram, the maximum is 31 days to the first treatment. But could it be, from a layman here, that some cancers need much more aggressive treatment, much less than 31 days, and others could perhaps even be longer because it's very, very slow as a risk? So are we just a little bit too generalist in this pathway?
Well, you could certainly make a strong argument for that. Yes, we are. But I think if it starts heading down the path of different cancer targets with different tumour sites, it will become very difficult to manage. But for example, if you have a fast-growing cancer, testicular cancer, for example, there are different targets for testicular cancer that exist. If you have somebody with a leukemia, for example, there are also different targets that exist. If you were to apply those across the board, you could say, for example, that prostate cancer, for example, doesn't necessarily, the data doesn't support a really fast diagnosis. Having said that, there are some prostate cancers that grow quite quickly. So you might disadvantage sort of subgroups by doing that. So I think what's come out of the consultation, the original consultation about cancer waiting times, is just the best fit.
So I think I'll go further on that and say there's still a lot of clinical prioritisation that goes along with these. So just because there's a number on it doesn't necessarily drive that patient. And we are constantly in conversation with our consultants and the clinical teams around what's right for that patient and right for that cancer. They are absolutely prioritised based on date and clinical priority. And unfortunately, that does mean we shuffle occasionally. And so those patients who can wait sometimes do if we need to get someone more urgent in.
Thank you.
Okay, so I'll continue with my presentation. Again, please just shout any questions or we can wait till the end. It's not that many slides. So these are 2-week wait referrals. So going back to what Kajal said, these are patients where there is a red flag symptom that they've seen the GP and the GP has referred them into the Royal Berks. There are 2 dotted lines on here. So the red dotted line is our pre-COVID average per week, and the blue dotted line is our new average from September 21 onwards. As you can see, there's a significant jump between those two. And it jumped kind of from a busy week being 500 to that now being a very slow week. We reached our peak just 2 weeks ago with 613 referrals. So it is an incredibly busy picture. It's unclear how this will evolve. You can see the shaded red area on the graph. Those are the patients who we would have expected to have seen but didn't present or weren't referred because of the COVID pandemic wave 1 with reduced attendances and reduced travel. Whether the growth is those patients coming through, whether it's that screening programs were suspended temporarily, whether it is increased health anxiety, different forms of GP access, it's a difficult picture to get to the causal factors on. I think from my point of view, we have to take an assumption, will it grow, decline or plateau? And I think the consensus at the moment is that it will probably continue to grow, but we're just not sure at which rate. So I kind of wanted to just draw everyone's attention to that very stark increase, which is in September. Not all areas have been affected. So for example, North and West Reading didn't see quite as big a growth as other areas did. However, by tumour site, we can see an inordinate effect in breast cancer. So yeah, potentially due to the screening issues, potentially due to parents, children, GP times. 53% increase in our referrals compared to pre-COVID, which is phenomenal. And add to that lower GI, gynecology, head and neck, they're all up almost a third as well. Interestingly, going back to Mark's point with, how can we get more patients in? One of the counsellors discussed, what are we doing? Prostate patients are particularly difficult to get to come to their GP. Men as a whole, getting to engage with something like that are difficult. And we've engaged with the Thames Valley Cancer Alliance and the local CCGs to promote some awareness of that and try and up those referrals. Indeed, there was an event just recently with the Lions Club to increase the number of men getting tested for their prostate cancer. In terms of our 62-day access standard, this graph shows 3 things. So the blue line is the Royal Berks performance, the grey line is the national performance, and the red line is the access standard, which is 85%. So that tolerance, if you like, allows for the complexity, patient thinking time, and some cancers being generally just more difficult and you have to get more specialist opinions on. As you can see, during COVID, we were oscillating just about 80%, slightly above 80% for almost 2 years. Then we've had a very rapid recent deterioration, although I'm happy to say a marked uptick in March. This was due to, alongside the normal issues we'd had, the increasing demand that we're seeing, but also some specifics in MRI capacity and in some specialist procedures. And they disadvantaged a couple of tumour groups predominantly, but as they're very big sites, it quickly was seen in the performance. The waits for the procedure have improved, I'm very happy to say, hence that uptick, and that was action taken very quickly. However, the scanning facilities are a bit harder to address and take a bit more time to do. We had planned for a mobile MR provider to come onto site for 2 days a week to start at the end of April. Unfortunately, that provider cancelled the day before they were due to start to operational difficulties. We have since sourced a second provider, but they only started scanning last weekend, so we are still working through their impact. So I suspect this will take a couple of weeks to recover, so that will be June performance still affected, but July performance should improve as a result of that. Was there any further questions or anything I didn't address in that? Sorry, so that's the particular deterioration.
Sorry, I have a quick question. Just on your comment regarding prostate cancer and encouraging men to step forward, I'm aware of national campaigns around this. Is there anything more that we could be doing in West Berkshire to perhaps even target patients where there's, for example, a history of prostate cancer? Is that something that we look at, or is that just too difficult? I'm not sure. Or if anything more we can do, because I know it's a national problem, but it seems to me, are we really trying to tackle it?
Answer that. Yeah. So I can try and answer some of that. So we can target our publicity, if you like, or our reaching out to specific groups of people. So you could sort of target, and we have tried to do that, sort of older men, men of an Afro-Caribbean background would be a good group to target. But also, we probably, and this work's just beginning, could target people demographically by GP, and we have some of that data. So it's possible we could target geographically, and even down to a small number of streets, even by postcode. But then you've got into the realms of, like, are you using that data in a responsible way? Personally, I think we probably would do. So it's an evolving picture, but we do try and target our awareness campaigns to specific groups as much as we can.
Thank you.
So one of the projects that Mark has led on, which he's very proud of and won a national award recently, is around and with the CCG and as our cancer champions, so working with Macmillan and local champions in different communities to ensure that they understand and are able to access our services. And that could be as simple as the right language in the leaflet and ensuring they know how to come in.
Yeah, sort of like particularly targeted the Nepalese, Polish and Urdu speaking communities, and that's been quite successful. And I think that sort of work sort of predicts the future, really. I think if we can reach sort of so-called hard to reach groups, I'm not sure that's true. I don't think they're hard to reach. I just don't think we're reaching out in the right way. I think if we can improve that, that will make a difference to all of our cancer sites, but particularly those which have a lot of men in them. They're a group that don't come forward.
Thank you. Councillor Macri, do you have a question?
Thank you. You said there is definitely an uptick just recently in this measure, but I'm wondering how confident you are that you can get up to that 85 percentile figure fairly quickly.
So one of my next slides shows you the position in the Thames Valley, but I mean, I would point to the NHS England position to say that it's an incredibly difficult picture across the country. There's a number of drivers for this, so not least of which is workforce. And in terms of, are we training enough doctors in the right specialties? Are we encouraging them? Are we making it easy to work with the NHS? And there's lots of different factors involved in that. We have been quite good, and one of my last slides is around our innovative roles that we've done. And in fact, 2 of the roles have been picked up by one of the national groups around what other areas should learn from. So that's around a nurse consultant who's specialising in breast cancer and physicians associates that we are kind of leading the way on. I think saying that I'm going to get back there with 100% confidence, I can't give you that. I can't say that. What I can say is we're taking it incredibly seriously, and we have an exec-led steering group that our first meeting is actually this Friday, where we're getting the clinicians, the matrons, the nurses all together with our exec by tumour site to go through their specific issues, their barriers, their perceived barriers, and then also what the future holds. So I've got my own ideas about what I would like to see. However, I'm sure they will echo many of those, but they will have more kind of granular knowledge from the ground. And that's the thing we need, I think, to build our strategy going forwards. I'm under no illusions, though, that workforce will continue to be one of the dominant factors at play.
Thank you. Does that answer your question, Councillor? Yeah.
It does answer it, but not the answer I was hoping for. But that's what I was expecting.
Sorry about that.
Shall we move on in the interest of time? Do you want to continue?
Yeah.
Thank you.
So this is our breach trend. So just to tell you, so breach is where a patient isn't treated within the time frame. So this is the 62-day time frame. So they're just termed a breach. As you can see, diagnostics dominate. So green is March. So February was the particular deterioration, and you can see exactly why there. And as you see, a slight improvement. Although I would say, January the issue started. That's never a small column, though. It is, as more activity is pushed down the same pipe, it is difficult to manage that pressure, and something has to give. And that's where we do clinical prioritization, investments such as the mobile services that are coming through. All of which is not simple, and there are, it's very difficult for us to manage against patient expectation and staff expectation, because nobody wants to see any weights creep up. And I have to say, I work with some of the most dedicated people I've ever met in my life to move these patients through the pathway. But sorry, I'll get off my box now. So diagnostics, complex, and patient choice are our biggest issues. Complexity we will always see. Cancer is a complex disease, people are complex. Patient choice, I think we have seen an uptick in patient choice since COVID, with different awarenesses, different takes on how we engage with them, and we have to respect those wishes, but we keep them on, we keep chasing, and we've got exactly the same priority behind them. This absolutely informs our actions going forward, which I'll come on to. And to give you a picture in the Thames Valley, because the national picture is always a bit different, you can see the Royal Berks is this green section here. We're achieving the 2-week wait, which is fantastic. So that's when you get to see someone, is often one of the key points about alleviating anxiety with our patients. 28 days, so this is diagnosing those with or without cancer. So 80% of the cohort of our patients had a diagnosis. And then 31 days. So once we've made a decision for the first or subsequent treatment, how quickly do we get that in? But you can see, unfortunately, the 62-day is not achieving then at 61%. And that's due to, as Mark was saying, that pressure to get all that diagnostics done. But I think it's important to note that just because we've made a diagnosis doesn't mean your tests are finished. So we still need to stage you to ensure that what we're giving you is the best treatment. There are molecular markers to ensure that you respond to the right chemotherapy. There is a very advanced test where we send you off to America for 2 weeks to ensure that your chemotherapy is targeted in the right way. It's a very difficult pathway with lots of moving parts and lots of steps. That doesn't mean we can't do better, and we absolutely are doing our best to do better. In terms of the actions taken, I spoke about the executive-led steering group. As I said, the first meeting is on Friday. I'm very hopeful that what we'll get from that is some engagement with the teams in terms of how do we turn this around, and kind of a momentum behind that as a yes we can, because we know there are lots of difficulties. We know it is a very hard situation coming out of COVID. We know teams' morale is impacted by the last 2 years. But we absolutely can do better for these patients, and I have every faith in my teams for that. We have recovery programs for histopathology, so that's enabling us to make decisions on those patients and make the adequate recommendations going forwards. Diagnostics, so particularly in CT and MR, which we have mobile scanners for. There is a plan for 2 MRI scanners to go in West Berks, which hopefully will be operational from December. A PET scanner, so that we're then not relying on the mobile or Oxford. All of these things are fantastic, but there is a lag time with them. I think kind of the evidence, if you like, that we take it very seriously. We're the first in the region to do the rapid diagnostic lung service, which for patients where it's applicable means they can come in, be scanned and be diagnosed and speak to their consultant on the same day, which I'm incredibly proud of the teams for pushing through. I think we have a colorectal plan in progress, and we're working on gynae and head and neck. I think those pathways take account of the personalised care agenda. Something very close to our heart is that just because it's rapid, it also needs to be incredibly high quality, and those patients need to feel reassured and supported throughout their entire pathway. As I said, we're quite innovative in our workforce and have 2 roles in the 4 national roles that are going out to people. We've also invested in CNS support workers to ensure our nursing team are able to work at the top of their licence, non-medical consultants, recognising some of the workforce challenges, and navigators, so that patients have a point of contact, almost a key worker, if you like, for those minor concerns which don't necessarily need a nurse. The last few bits are kind of the quality elements that we're doing. So cancer rehabilitation, so making sure people are supported post-treatment and discharge, as the feedback we get from patients is that they can often feel, they've gone from weekly reviews or 3-monthly reviews, depending on who you are, to, yeah, you're fine, off you go. And that can be quite a jarring experience for people, enabling them to get back into work. The EDI work, which we briefly touched on, that Mark and the team have led on to get into and ensure we have access and make it easy for those harder to reach groups, despite how we don't like the terminology, to come forward, to ask for help, to be treated in a respected way. And I think the real push here is, with everything in life, things are becoming more complicated. It feels like the mental load is increasing for patients every day. Do we do enough to support on psychological support, on dietetic support, on speech and language, sexual, relational, all those holistic elements that come together to enable you to get back to being you? Cancer is a devastating time for anyone, and the anxiety and the fear it can engender are huge. And I think I'm really proud to say we take that really seriously, and we're incredibly good at supporting them, but recognise there is more we can do. That was the end of my slides. I hope that's okay, and I'll stop sharing.
Yeah, thank you very much for that. Before I open it up for questions to members, I just want to point out that we have a technical problem with the camera in the council chamber, which is why you can't see anything at the moment. So we are working on it, and hopefully we'll resolve that issue. Councillor Linden.
Thank you, Chairman. Just to go back and thank for the presentation. How do these figures go locally? Both in Berkshire West and West Berkshire Council, but also the further population, as I asked to it, because obviously we've got a positive campaign. How is it relating at the moment, and how do you foresee it relating in, say, the next year or so, briefly? Thank you.
So in terms of the data that we've supported, so all of this is local data. I haven't split it down by PCN or geographical area. I mean, I can do a percent another time, but largely, if you take the aggregate, they're pretty similar across most of ours. We have South Reading with a higher deprivation that probably has a different profile. Is that what you're asking? Sorry.
Yeah, and also how it affects locally. I think Andrew wants to come back on it in a minute as well, Andrew Sharp. But if you could just give us an idea of roughly what's happening locally. I mean, obviously you mentioned about South Reading.
I think, generally speaking, the West Berkshire figures and the Reading figures and our performance, even though it's been in the doldrums since September, it's no worse than the national picture, and in many places significantly better. So I think how that transfers, how that translates into the experience of people, I think is also what you're asking. I would say that the National Cancer Patient Experience Survey that was done last year, which we were, there was nothing to force us to do that. It was actually completely voluntary. Normally it's compulsory, but in COVID times it was voluntary. We volunteered to do that. And that shows that, generally speaking, the standard of our cancer care has been maintained, which is reassuring. I mean, there's been the slight deterioration overall in line with national figures, but in terms of actual patient experience, I think we can be reassured that we managed to, against the odds, trying to maintain that patient experience. But I think you can be reassured to a point that even though there's been a deterioration around our diagnostic capacity and our ability to cope with patients, that's not out of line with the national picture. Does that answer your question?
Yeah, sorry to come back. On the actions taken, how do you foresee that making an improvement in your area, basically? Would it be significant, or is it going to take quite a long time or so?
So that's a good question. There's lots of moving pieces towards this, and what I find is by the time you solve one problem, you're often anticipating and working on the next. But I think the national strategy around the community diagnostic hubs and increasing our diagnostic capacity is absolutely a pivotal change. The histopathology work, which is largely workforce related, with a future plan to digitize that and ensure that reporting can go, around the world with IG compliant services. That's kind of 2 years away. But I think those will make a marked difference in our performance. I think the biggest single thing that, if there's any influence from this group, is around that workforce and ensuring that we are training a workforce for tomorrow. And I'm not sure what Nicola's just said, apologies.
So just to read out what Nicola's just commented, some of the issues are much wider than our strategy and ways of working as are linked to a pipeline of workforce. Thank you for that. Councillor Linden, does that?
Yes, thanks, Chairman.
Councillor Macro.
Thank you. Pathology. I remember a family member was going to have a procedure recently. It's called to the assessment unit at Royal Berks. And we spent all afternoon waiting for test results, and only to find that one test was rejected by pathology, and called in a second time, again spent all afternoon, didn't get the results. And this issue of blood tests being rejected by pathology is something is fairly common in my family's experience. And I just wondered what is being done to address those kind of issues.
So I'm very sorry you had that experience, and certainly more than once. I think with our pathology systems, we do have a significant workforce. We have invested very recently in our biomedical scientists who help with the labelling and processing of those samples. It's the consultant posts that are proving very tricky. That said, I wasn't aware that's a common outcome among potential cancer pathways. But if that's a more general common pathology, I'm very happy to take that back and ask them. I suspect from speaking to them, so things that we use on the cancer pathway, such as a fit test, if the wrong label is attached in order to comply with their own safety protocols, they aren't able to then process that in a timely fashion. But without looking into that case in particular, I'm not sure I can comment any further, sorry.
Thank you.
Thank you. Are there any other questions? No? Okay, well, Thank you very much for that presentation, which is incredibly helpful. Can I invite Dr. Patel to present on the wider cancer priorities of Berkshire West CCG?
Thank you. So I'm going to ask Peter Hunt, my project manager, just to share the screen for my slides. Thank you. So thank you for inviting me to speak. My name is Kajal Patel. I am a GP in Reading. I am also the GP cancer lead for the whole of Berkshire West. So what that means is I work in partnership with primary care, with Royal Berkshire, with patient groups, with our cancer charities, with all of our partners in trying to improve our sort of cancer awareness, our pickup of cancer, our referrals of cancer, and looking at how to just streamline and make the experience and the process better for patients on a whole. I've been working in this role since 2016, and when I first joined the CCG in 2016, I was asked to lead a cancer steering group, and I have to say, hand on heart, I work with a fabulous team. And if I can give you a glimpse of what it's like. So the cancer steering group happens every month, and we have attendance from Chris and his team. So Mark as the CNS specialist, any of the other CNS specialists, Catherine Bailey, all of the relevant people will come to that meeting. In the olden days, when we had GPs representative of every single area in Berkshire West, we would have a GP from Wokingham, a GP from Newbury, a GP from Reading. Basically, they're locally representing their area. We also have public health that comes to the meeting. At the moment, we've got someone called Susie Watts that comes and brings that public health element to it and tries to line up what public health are doing for campaigns, as well as what we want to do on our agenda. We have the Macmillan Cancer Charity executives that come to that meeting and project managers, and we also have CRUK facilitators, and we also have the Thames Valley Cancer Alliance project managers attend. So we have a whole host of people that come together for this specific meeting, which is local to our area, and that's probably the best platform that we get a lot of work done and a lot of progress made. The benefits of me being in the system since that time is also the relationship that I have with the consultants, with the practices. And actually that means that if we want to change something, or if we think that something needs changing, we can actually do it quite quickly, which is a real advantage. And I'm lucky to have such a fabulous team that I work with. So I'm going to give you a little bit of a glimpse of what we do, and there's lots of stuff that we have that you can contact Peter for, and he can give you. When I first joined, we wrote a cancer framework for Berkshire West, which we then refreshed a couple of years later, which we say what the local priorities for Berkshire West are. The last couple of years, we've been working hard, really in recovery from COVID-19, working with our system partners to look at what we do. When Chris showed you the graph of the red and what we've tried to do locally to get patients in. We had a prostate campaign in November. We had various webinars that we did. I did lots of evening talks with patient participation groups, encouraging patients that if they had red flag symptoms, then not to be scared of COVID, and actually to go and see their GP, and not to be scared of going into the hospital. One of the videos we did actually showed patients the kind of measurements we take to keep patients safe from COVID. And for those of you that go on to watch the video, you'll recognise Mark in that video. One thing that we touched on is Cancer Champions. This was an idea that stemmed from the fact that when health professionals or doctors talk about symptoms or go and have your screening, we felt that was a different impact to someone in the community. So actually grassroots people talking to the community, saying, I had this, or have you got this, or have you heard of this? And what was born was a group of initially 20 people, volunteers, that came forward that said they'd like to be cancer champions, and they went through a Macmillan training program free of charge. And we've now got about 40 volunteers that have been trained to basically go back into the community and to share what red flag symptoms are. They can share it in different leaflets that we created in different languages, and they would take the message home so that they would be able to crack some of the cultural barriers that I think medics were facing. So that project that was born initially just in South Reading has expanded, and it now covers the whole of Berkshire West. And there are so many projects that they've done, stalls that they have, Reading Festival, lots of stalls, Broad Street Mall, where they really try and encourage the general public to try and recognise symptoms and be confident, and then go and attend their GP. Another project we worked on was the Cancer Collaborative project, which was mentioned earlier, and that was about making our cancer test leaflets and results more applicable to patients from different languages. So Polish, Urdu, Nepalese, and the team did great work with that, and they won a national award recently for that. One of the other projects that the CCG has asked practices to do is something called the Quality Improvement Scheme, and that directly relates to what Andrew mentioned earlier about looking at diagnosis of cancer and getting patients diagnosed with cancer earlier. And part of that quality improvement scheme, we've done a couple of things as the CCG. We've asked practices to focus on increasing their screening for breast, bowel, and cervical cancer. We've also asked them to focus on traditionally groups that have been low uptake groups for cancer and for attending healthcare appointments. So the learning disability group for mental health patients. We also introduced something called an audit we asked practices to do, which is routes of analysis. So practices would sit, and every single time a patient is diagnosed with cancer, to do a route analysis of what led to that patient's journey of cancer. How many times did they present to the GP? Were they referred on a 2-week way pathway? Were they picked up with a cancer through another pathway? And to really look at what local clinical learning they had. And practices would write back to us, and Peter and I would review all the paperwork. And there were some real good lessons learned about practices writing back saying, we noticed that we needed to do, so I can share my practice. My practice noticed it had 3 ENT cancers being picked up quite late. So we asked one of the ENT consultants from RBH to come to the practice and to give us a slideshow on ENT cancer. So other practices had other learning that they shared, which again was a way of making the practice quite responsive and to be responsive to your local populace. Another project we've done is cancer care review schemes. So patients that go and are diagnosed with cancer have care from their consultants and their nurse specialists, and also encouraging then GPs to touch base with patients and to keep that relationship open, because sometimes, because cancer is quite specialised, patients go off to the hospital and then they think everything is done by the hospital, but actually making sure that there is a link to primary care, and where GPs are very good at plugging people into the voluntary sector. So for example, when I do my cancer care reviews in my practice, a lot of the time I will refer patients to the social prescriber, who will be connecting them to voluntary services and various things that they're experts in, which can actually make a big difference to patients. We're also working on personalised care, and that means a variety of things. So patients that go into hospital and diagnosed with cancer have holistic needs assessments, and these assessments are done twice in their immediate cancer journey, looking at what needs they have and how to meet them. As they reach towards the end of their cancer journey, a end of treatment summary is produced, which is a document that's sent to the GPs, which basically have all the details of the patient's cancer, their treatment, what their follow-up is going to be, the kind of symptoms and signs to look out for reoccurrence. And that, again, that's something that we introduce as a way of really marrying up the journey and having something for a patient to have at the end, which primary care could have and know what they were going to do in the next few months or years if necessary. We've worked on various wellbeing events which have been really popular within our cancer rehab service, and some of them have been great. You know, we've been lucky that we've had funding, and we've had psychologists that have talked about things that sometimes it's really hard to get help with. So sleep disturbance, sexual dysfunction, appetite changes, eating, lots of things, and therefore the rehab service has been brilliant at that. We've had a public prostate cancer awareness campaign back in November, and that was a way of trying to get the lower numbers of patients that we thought had prostate cancer to come forward. We've also been working with the Lions Club, who obviously do the voluntary PSA packs, because obviously the PSA blood test is one thing, but actually once that's positive, going through the Royal Berkshire system and for the patient to go through that process to actually have the test to say, do they have cancer or don't they have cancer, has been something we've worked through as a system. We've also done lots of GP support and education, and some of that support and education has been through COVID and pathway changes. Some of it has been with new innovative tests that we've used. We introduced the FIT, which is fecal immunochemical test in our symptomatic bowel pathway, and just really getting the story out to general practitioners about how to, how patients do it, how patients access a video, teaching them how to do it, where the test goes, how to order more bottles, all of those things that we sort of take for granted, but that's the kind of things that the CCG will support on. In September 20, we introduced the local vague symptom pathway, and I think that was a real monumental time, because we noticed that later cancer presentations sometimes can be if the symptoms have been vague, and that's where we introduced this vague symptom pathway, where patients can be sent on that, and they're worked up to look for a potential cancer, which has been really successful, and the feedback has been great from GPs, because they had a portion of patients that they would see that they think, I'm worried about, but actually I don't think they've got lung cancer because their chest x-ray is normal, or I don't think they've got bone cancer because this is normal, but actually who do I send them to? So this has been something that's been really helpful for primary care and for secondary care, I think, to try and see if we can pick up any cancers, because cancers that we pick up earlier are easier to treat. Last point in there is just highlighting the cancer steering group that we meet monthly, which we have done for years, which I think is a real driver in our local system, and I think we're all quite proud of what we've achieved through that. Lots of things in the future, probably too much for me to mention in the interest of time, but we're going to continue the Cancer Champion work, which we've got more funding for. We're going to, we've done a faster diagnosis pathway for lung, and we're working on a faster diagnosis pathway for colorectal. We're working on new posts that sit between primary care and secondary care, where the personalised care nurse facilitators can look at cancer care reviews, look at the barriers in accessing cancer care reviews for different health inequality groups, and looking at ways to reduce any variation amongst the practices. And then we're looking at more personalised care. 1 in 2 of us will get cancer, that is a fact. And actually, as we become better at recognising cancer and better at treating it, cancer will become a long-term condition. It won't be that, like years ago, you potentially could get cancer and you may not survive from it. Actually, it may be in your past medical history now, but there are ways that we have to keep those groups engaged, and we have to keep screening and various things open for them. So actually, it's looking at how we move forward with personalised care within cancer as well. So that's really just a flavour of how the CCG supports cancer in terms of the work that all of our partners do. I'm very happy to take questions, and Peter's very happy to share any resources that you may want to have as well.
Thank you, Dr. Patel. That was for that excellent presentation. So I'll take questions from members. Councillor Macro, is that a legacy hand or is that?
Well, it was, but I was going to.
You've jumped in front of the queue, so the floor is yours.
So, it's my impression, based partly on personal experience, that since COVID-19, the number of kind of regular reviews by GPs has gone down dramatically. You know, once upon a time, people were called in for prescription reviews. Diabetics were called in for diabetic reviews and so on. A lot of that doesn't seem to have kind of built up again after COVID-19. I was wondering if this kind of lack of regular contact with GPs is something that's going to store up problems for the future.
So I think I guess I can only talk for the practices that I engage with and my own practice. So we call people for reviews as per normal. One thing I would say to you that has really changed as a GP post-pandemic is that the pressure of access has really gone up. So unfortunately through COVID, there is a lot of health anxiety, there is a lot of mental health. And so actually where patients would probably self-regulate, use pharmacies, use over-the-counter medications, I think there is an element where people, because they're more anxious, are presenting more. And sometimes that has an enormous pressure on your system, because if you are set up to have, unfortunately, the way the reality of the situation is one GP per 2,500 patients, you're not going to have an infinite amount of appointments. So we definitely do try and meet all of our targets, and medication reviews and diabetic reviews and all of those things are important and they are vital. And as a practice, I can say we have worked very hard in getting up our numbers. One thing that has changed is, because of the difficulty in recruiting, is that we are using more of our team members to help with some of those reviews, if that makes sense. So sometimes the practice will use a pharmacist to conduct a medication review in place of a GP, and that simply comes down to numbers. Ideally, we are thousands and thousands of GPs short, and I can honestly tell you, I've post-pandemic, yesterday I wasn't on duty and I got home at 9 o'clock. Unfortunately, through the pandemic, what happened is pathways of accessing GPs opened up digital access. So actually the amount of digital access has gone up. So a lot of things that would in the past be an appointment, actually you might open your surgery at 8 o'clock in the morning and you've got 400 emails waiting for you. And some of those emails are from cancer nurse specialists asking us to start morphine for a patient, or asking us to start an urgent medication or thrush or something. Some of those might be from district nurses, some of them might be from the hospital or social care or patients themselves. And then you've got your appointments that fill up your system. So what classically happens is you do a whole list of appointments, and then you've still got your prescriptions and then your digital forms of access that have been opened up, which you are still therefore answering. So your actual points of contact as a GP have, I would definitely say, have doubled or tripled. And if you look at the analysis of GP appointments, I think there are 61.3 million appointments done at a point in time compared to a lot less pre-pandemic, and that is just because of the way that the appointment structure has changed and the points of contact have changed. I will get maybe 8 or 9 requests for a sick note, just as a little note to Dr. Patel, which in the past might have been an appointment. So what you're doing is a good 3 or 4 hours of administrative workload on top of your full clinics. I don't know if that answers your question, but I was hoping to give you a bit of background, which looks at sort of, we are trying to do normal reviews, but we're also trying to cope with the increased pressure from increased appointments. Also the fact that we've had significant recruitment issues.
Thank you.
If I could just come back on one thing. It mentioned that some practices are using pharmacists, for example. My practice uses a pharmacist and also a paramedic. Does this mean that those appointments are less likely to pick up on cancer?
I guess it depends on what the appointment is for. So the pharmacist doing the medication review, there will be a very specific template that the pharmacist follows. So the medication review will be, for example, someone that's got a low functioning thyroid. So if you're on a thyroid medication, you've got low functioning thyroid, and it's been a year since your last blood test, the pharmacist will phone you up and say, hello, Mr. Smith, you're on thyroxine. You haven't had a blood test for 10 or 11 months. I've requested a form. Please either go to the hospital or have it done at the practice. We'll get the results a week later. If the blood test is normal, we can authorise your prescription again for another year. And that's what a medication review is, to really look at the medication they're on and to see that it's sensible and to see that blood tests are done and blood pressures are done. In terms of cancer, red flag symptoms will always go to a clinician. So they won't go to an allied healthcare professional if they've got a red flag symptom, unless it's part of that scope of a paramedic. So, for example, we have a paramedic in our practice, and our roots of cancer last month showed that she'd seen a patient who had a sore throat lasting more than 3 weeks, which met the criteria to refer her in to be seeing on the cancer pathway. And we see lots of sore throats, but she saw this patient, he'd had it for more than 3 weeks, and she referred him on the cancer pathway, and he did have throat cancer. So if it's within the scope of practice, which is how the appointment is booked, then actually, regardless of whether you're a paramedic or a GP, you know about red flags and you know how to manage them. But it really depends on the reason for your call. We would never book someone who was unwell for the pharmacist to see, and it depends what your scope of pharmacists are. But for most clinicians, they will only see what is in their scope of practice. It's a bit like if you've got a heart problem, Chris won't book you in to see his urology cancer surgeon, because that's not within his scope of practice. And practices are set up in the same way. So our allied healthcare professionals, there's a list. So the paramedic has things that they will see and things that they won't see. So paramedics, for example, won't see rectal bleeding because they're not trained in doing a back passage examination. So they won't see someone with rectal bleeding. Equally, they won't see a pregnant person, or they won't see someone under 2. So those scopes of practices are unique to each clinician, dependent on their training and their diploma status, and that is available for reception before they book a patient for you to see.
Thank you. Councillor Brooks.
Thank you, Chairman. A couple of observations and a couple of questions, I think, really. I'm looking at there isn't a page number. You talk about personalised care, and then on the same page, public prostate cancer awareness campaign, GP support and education. Have you got the page?
Peter, can you get that up?
Yeah, achievements in 2021, personalised care, public prostate cancer awareness campaign, GC support and education. Have you got that one? Can you see that one? It was yours. You went through a short while ago.
Is it a comment, Councillor Brooks, or a question?
Yeah, just making sure the lady has perhaps got that on her screen, because I'm trying to find my words carefully here, but I find a lot of the phrasing and the words impenetrable. And I think any member of the public, and as a layman sitting here now, I have no idea what the implementation of a breast risk stratified pathway in secondary care has. I haven't the faintest idea. And on GP support and education, webinars around fit, symptomatic and local vague symptoms scan pathway, support pack created for cancer earlier diagnosis element of the PCN DES 2122 and QOF QI cancer ED module 2122. It is your own internal jargon, and you can't expect us to really have any understanding of that sort of terminology. I make it as a note. I note it because if the health profession, if the health services speak to patients like this, that will be the worst of outcomes. They're scared patients, and they really do need to have these points demystified. I'm going to leave it there, but I think you've given us some very good examples of how some of your vocabulary and phrasing is impenetrable. I think the point about your 400 emails, and I sort of do sympathize, but I wonder if the profession has made itself a little bit too open to the digital age. I would never have thought actually I could email my doctor directly. You've given me something to think about. But once you open it up, that everybody can send to your inbox, more and more and more and more people will do so. And therefore, that perhaps you are trying to be more open and more engaging and inclusive, and have given yourself a problem as a result. And people who run big corporations have a lot of filtering of emails and communication to be able to manage that load. And I suggest that's something you might want to look at. And finally, could you give us some examples of what a champion might do? Just one or two things they can do, because it's an overused word now. And so what might a cancer champion do? Do they have a budget? Do they have any resources around them? I presume they are a professional, a health clinician or worker. What can they do? Thank you, Chairman.
Thank you. So apologies for the jargon on these slides. We will definitely change some of these titles. I suppose that the slides have lifted certain projects that are being carried out, and some of them unfortunately do use jargons. So a little bit of explanation on what that means, and I didn't, in the interest of time, want to talk at length about it, which would have made it clear. So GP support and education and the webinars around the fit symptomatic was about the webinars around the stool test that we were doing, which patients produce if they've got a change in their bowel habit, looking for blood in their stool, which if it's positive, then that goes on the cancer pathway, if that makes sense. So it was a new test to use in patients that have a change in bowel habit, looking for blood. So before getting patients onto a colonoscopy, making sure that their fit test is done to look at whether that fit test is reassuringly normal or it's abnormal and they definitely need that colonoscopy. The local vague symptom pathway was, as I said, the suspected cancer of unknown pathway. Practices were encouraged by NHS England to form PCNs, which is clusters, primary care network as clusters. So the practices weren't working single-handedly, and they worked in a team of 3 or 4 practices with a populace of 30,000 upwards. So the PCN is the the cluster of practices that your practice will be part of a cluster of practices. And part of that is to share resources. And part of the scrutiny of NHS England, when they ask GPs to do something, they will look at it at a PCN level. And there are importances in that, because if your local populace, for example, is at particular risk of something, you can actually target that cluster of practices and say, this is what we want you to focus on. And it's a bit like what Mark earlier said, which is he said that you could actually look at postcodes. And in Berkshire West, we'd actually done some postcode analysis for lung cancer, and we'd identified certain geographical areas that had higher forms of lung cancer. So the jargon, I apologise, is the cluster of practices, and the DES is basically the system requirement of what practices have to do for their return for NHS England. And as a CCG, we will support practices in what information they need to do the work that NHS England is asking them to do to improve quality improvement cancer. And it's looking at the resources for practices to do it as well. So clusters of practices, for example, will share a social prescriber, or they will share a pharmacist, for example. Your other question in terms of the emails, yes,
Digital access and email overload.
So you're right. It is difficult, and what happens in my practice is we do have a manager who looks through all of them and then will signpost urgent ones to the duty doctor so that the urgent ones can be done. It is a fine balance to navigate between removing access or reducing access in a time that we are trying to encourage patients to come to their GP. You know, as Andrew mentioned earlier, you know, we are encouraging patients to ask for help, to see if they need a review, to see what medical help they need. And absolutely, practices will need to navigate the fact that these digital forms of access have been increased, which is why practices are dealing with an increased workload. But that has to be done carefully, so that we are still being mindful to patients that want to ask us those questions.
The other one was champions.
Oh, champions, yeah. I'll give you an example. I attended a talk at a community centre which was held in Reading. Actually, it was the one in Reading by Eldon Street. And it had 23 women there who were there for doing various things, but there was a talk on cervical screening. So some populations don't know what a smear test is. If it's a cultural barrier to talk about cervical smears, they may not actually know what a smear test is. So the Cancer Champion had invited these women and had essentially in different languages had leaflets on what a cervical smear is, what it means, when you need to have a smear, how you have it, what is a smear, who does it, can you request it to be a nurse, can it be a doctor, can it be a female, can it be done with an interpreter, can it be done if you're on your period? You know, some of the basic questions that we probably think people know. Cancer Champions will probably take those messages back to their communities and say, actually, this is this. So that was one example. Another example is a Cancer Champion doing a talk in a mosque, talking about bowel screening. Because again, in certain cultures, people won't want to talk about stool or bowel or poo, and it's actually having someone that isn't medical, because sometimes your mind switches off when they're medical, but having one of your own peers saying, actually, this is really important. It is a bit of a faff doing this poo test, and you've got to stick the thing in your poo, and then you've got to label it up, and it's all quite embarrassing. And actually just having some of that information in a place of non-confrontation, you know. So some of these talks are done in religious places, some of them are done in community centres, some of them are done, like I said, at Reading Festival, which is just, by the way, did you go and have your mammogram this year? But it's basically the champions that will choose something that they want to go and talk upon, and an environment that they're happy to talk on. So one of our lead cancer champions actually talks on the Nepalese Gurkha radio every Friday morning, and she chooses different topics to talk on. Have you had your COVID vaccination? Have you had your smear test? These are red flags, and she will invite, you know, various speakers to her radio show to talk about it. But essentially, they're trained to be able to identify what a red flag symptom is in order to communicate it with a patient. And they use a specific Macmillan leaflet, which is a picture of a body, and then it's got, you know, your head, your chest, your tummy, bits of the body, and it will say things like, skin, have you got a mole that's changed in size, that's bled, that's irregular, that's itchy, that's a different colour? And it will just be basically telling people about things that they need to be looking out for in their own specific groups. Does that answer your question?
Thank you, very helpful.
Thank you. Councillor Linden.
Thanks, Chairman. Yeah, just a couple of points raised by members. I've got an experience now that I think my own surgery is more access than they had been at the height of COVID. And people can come in and there's tests, as you can say, on reviews like diabetes and whatever. And I have another thing which I need to go into. Certainly when we had COVID, there was potentially a receptionist barrier that they're not medically trained. So it's got to make sure that with the amount of extra use that there are limitations, obviously, what a receptionist can do. They do obviously a very important work, but obviously medically that's different. But there's also, and one thing that's come up, and this has been pre-COVID as well, I suspect there's a shortages of pharmacists. And I know the pharmacy I use is owned by a London group, and the pharmacists that come in are from London, and they soon get fed up travelling to the pharmacy in this district, and that can be a problem, and that might be something that does need to be looked at, because I suspect it's wider than just this pharmacy as such. You know, people are quite entitled to buy up pharmacies, but also to provide a regular pharmacy coming in. And it's always difficult recruiting somebody from a fair distance away, especially with traffic and now with increased fuel costs. I just wanted to throw that in, Dr. Patel.
Yeah, I mean, I think you make a good point. I think pharmacists are an interesting profession, and I had no idea, but there are different areas that they specialise in. So some will be clinical pharmacists and they work in the hospital, for example, with Mark, making up chemotherapy and making up medications for cancer. And then there are some pharmacists that are community pharmacists that will specialise in retail and dispensing of medications. And then there are some pharmacists that are industrial pharmacists that specialise more in the making of medications. Primary care pharmacy is a new phenomenon, and I think that's to reflect the fact that primary care is changing. Let me give you an example. 30 years ago, if you were going to start someone on a tablet called Ramipril, you would send them up to the hospital because it was a tablet that can drop your blood pressure too much, it can affect your kidney function, and you would go to the day unit and it would be started in hospital, and they would monitor you, and if they were happy then they would say fine, go home, and go home on it. Primary care now has changed so much so that we don't just start one medication for high blood pressure, we actually start up to 4 medications for high blood pressure before the hospital team would feel it was in their place to get involved. So primary care is definitely changing a lot, where we are doing more that we've done previously, things that are more specialised in primary care. And that's where actually the pharmacist can be quite helpful. So for example, my pharmacist, last week, I had to email her and say, this patient's pregnant, she's got, unfortunately, this condition. The specialist has asked for this medication to be started. They gave her a prescription, but the pharmacy can't get hold of it, and it's actually out of stock right now. What can we switch her to? And actually, it would probably take me a long time to get through and decide this would be the next best thing. Let me contact the pharmacy. Let me decide. Actually, what she does is she's got a WhatsApp group with all the 20 pharmacies locally on that WhatsApp group. So she looks up the medication that's most like the medication that the specialist has asked for. She'll put on that group, have any of you guys got medication X? And one person will go, oh, yes, we have. And she goes, great. And then she'll send me a little task to say, dear Dr. Patel, please give drug X and please send an electronic pharmacy prescription request to this pharmacy because they've got it. And then I can send a text message to the patient, say, thank you for contacting us. Your prescription has been sent to X. Now, in the olden days, what would happen is I'd probably have to write to the hospital specialist saying, well, thank you for starting this lady on X, Y, and Z, but unfortunately she can't get hold of it. What else would you suggest? And then they would either write back and then we would prescribe it, or they would have to see her or leave her a prescription. So things have changed, ways of working have changed, and therefore there is I suppose, a portfolio for a community pharmacist who has a knowledge of medication, who has a knowledge of minor illness, a knowledge of interactions of medication. And we've got pharmacists that, for example, will specialise in diabetes, and they will therefore be able to counsel patients in more time to say, well, this tablet gives you this many side effects, or these are the things you've got to watch out for. And that time it takes, actually, it's far better spent with a pharmacist doing it, because I can see 3 patients in that time. So the ways that unfortunately primary care is changing, and that the whole of healthcare is changing. You know, Chris mentioned that they as an acute trust have appointed nurse consultants, they've appointed physicians associates. There is a new way of working in the NHS to meet the demand and to make sure that everybody does work at the top of their license. So that means that actually, I don't see anyone with a sore throat. I don't see anyone with a cough. I don't see anyone with a urine infection, because all of that stuff, which is kind of bread and butter and easier, tends to go to my acute practitioners or my duty doctor, and I will see the patient that's 88, that's been diagnosed with lung cancer, that's on 18 different medications, and they've got about 4 things they want to discuss. So that it's the fact that in my training as a GP, I can probably look at all of those things and decide what we need to do. And actually, little Johnny, who's got a cough, actually can see my nurse practitioner, because he can come in, he can have his temperature done, he can have his chest listened to, his ears looked into, his throat listened to. And that's the division of workforce that is happening. And that's happening in primary care, in secondary care, right across the system, so that we actually get patients the care they need at the right time.
Thank you. Councillor Bridgman.
Thank you, Chairman. Very quickly, just to inform Councillor Linden, and indeed inform all members, that there's a West Berkshire pharmaceutical needs assessment in draft, and that was put out to consultation on Friday. And when I leave this meeting, and I'll have to meet very shortly, Chairman, for another meeting, I will be sending an email to all members inviting them to take part in the consultation. So, you know, there is an opportunity for Councillor Linden to be heard on this subject.
Thank you very much, Councillor Bridgman. I'm sure Councillor Linden is delighted to hear that. Are there any more questions? Conscious of time, but anybody else have anything to raise? No. Can I just thank Dr. Patel and Chris and his team for joining us this afternoon. I really do appreciate your time and the presentations that you both gave. So thank you very much indeed. You are welcome to stay, but I'm sure you may have more pressing things to deal with. So members, there is no recommendation associated with this report. You're simply asked to note the reporting and consider, if you wish, any further scrutiny work on matters raised in the report to be included in the future of our work programme. Moving on to agenda item number 7, which is Berkshire West CCG update. As you're aware, Belinda Seston has given her apologies, so there is no update at this meeting. So moving on to agenda item 8, Health Watch report. I'd like to invite Andrew to report on current activities and feedback from local residents. Thank you, Andrew, and thank you for your patience.
Thank you, Chair. I'm going to keep this pretty brief because we're obviously very tight for time. So the sort of major things we have been up to since last meeting, one of the key things has been surveying some of the asylum seeker hotels in West Berkshire. We have a survey going in talking about health needs and interactions, and I think the one thing that really comes across from the whole experience of being in all the sites is the fact that, if anything, the mental health requirements may not be being met. And while we realise mental health is a challenge across the whole system, you know, we're working with Reading refugees and things like that, and it was pointed out that, you know, the incident both in Reading and in Glasgow, which resulted in some serious harm, was mental health related. And I have written to all 3 chief executives across Berkshire West to highlight this. I am not highlighting there is a failure. I'm just highlighting that we have a lot of people here who, some of which don't have a great deal to do with their time. And on my last visit, the first thing someone mentioned to me, not unexpectedly, was Rwanda. So we just have to be mindful. I would also like to praise Thatcher Medical Centre, Thiel Medical Centre for doing some remarkable work, but it is something we'll be able to report back in more detail. Other quick note, I'm very pleased to report the CCG has been talking to us about actually creating some sort of maternity forum for West Berkshire, because the traditional maternity forum tended to be focused around a particular hospital trust. And of course, as we've talked about before, people pregnant and giving birth in West Berkshire can potentially go to 4 different trusts, the bulk of which go into Royal Berks, Basingstoke and Great Western. So of course, although they've all got maternity voices, they only ever talk particularly about one. So this is a really interesting opportunity. I will update as soon as I can. Thinking Together 6, our mental health service user, public and professional event, looks like it's going to happen October, November time, based around children and adolescent mental health. So again, very key in terms of timing. I'm just delighted with the positive uptake we've had in terms of people who want to get involved, from Berkshire Youth, from CCG, from West Berkshire Council, and all strands. So I think that will be very positive. So again, I'll report back on that. And the other 2 things I just wanted to mention. One, I would just remind the board that, you know, we had talked about continuing healthcare as an item, and I think you know, I was hoping the CCG will be able to update us today on that, and sadly, because of apologies, they aren't. And I just think it is just something. It was raised with me again. It's a very small cohort of people, so it's very, very difficult. They are generally so busy looking after the person that fighting the good fight is difficult. And I know the CCG are looking at it. We should look after it. And then finally, again, children's mental health situation, the situation with Huntercombe House and CQC, I think requires considerable scrutiny in terms of the recent CQC report, which seems to show that it is not improving in the way everyone had hoped. That's, I think, all I want to say, Chair. So to be brief, thanks.
Thank you, Andrew. Members, are there any questions? No, that was very helpful. And thank you for being brief, but always very welcome in terms of your updates. We may want to move you a bit further up the agenda, actually, Andrew, maybe next time, so that you're not right at the end. So we'll have a look at that maybe for future meetings. Okay, so moving on to agenda item 9. So this is the protocol between West Berkshire Health Scrutiny Committee and local health bodies. Just to advise members that following discussion at the Health Scrutiny Committee on the 5th of April, some amendments have been made to the protocol, which I think most of you are aware of. These are to confirm that it is not an agreement, but a way of working that West Berkshire Council wish to adopt. It also references the health bodies who we work with. We will, however, continue to consult with other health bodies. So the recommendations are, firstly, number 1, to endorse the final protocol and the process for dealing with proposed substantial developments of variations to health services. And number 2, recommend the protocol for approval by the Health Scrutiny Committee. Do I have a proposer for that?
Any questions?
Oh, sorry, any questions on that, first of all? Councillor Brooks.
Yeah, I was able to look through this and find some good ways of working in this. There's I just get the page number, page 125. I note the bullet point 5, the overview and scrutiny approach is transparent, collaborative, constructive, and non-confrontational. That's how you would want it to be. And so I was pleased to see that it's based on asking challenging questions, because I think the public would expect us to ask the tough questions. I'm a substitute today, but what I have observed, and not entirely, but some of it has been more informing us and presentational, which is good in its way, but are we going to be able in the future to really scrutinise something and come up with recommendations? And I'm sure that's where you're heading, Chairman, because unless we're going to ask those challenging questions through this protocol, and then part of our work is to say thank you for that, and we suggest the following, we can't mandate, then that's not in the protocol, because that's the way of working. But surely I'd expect us to want to get to that end game, if you like.
Does anybody have any comments on that, or was that directed towards me?
I think the members in general on the Scrutiny Commission, perhaps even officers, that we're here to be informed, but we're also here to ask those challenging questions as per the protocol, and then come up with some suggestions or requests, if you like.
Yeah, we did discuss this on the term when we were discussing the terms of reference, and actually a large part of our role being that critical friend as well. And I think one of the challenges that we face, Councillor Brooks, is and I appreciate you're a substitute, this is your first one, is that the level of detail in some of these reports and the presentation, which is incredibly important to get the background and the information. I think sometimes we are trying to look at actually sort of condensing that down in terms of the presentation, which will allow us then to perhaps put some more questions or searching questions to attendees. However, I will draw you back to that critical friend piece. We're not here as a firing squad, and there is a limit to the recommendations when you are particularly, I think, up against NHS challenges, which have come out on a number of health committees, health scrutiny committees that, particularly post-pandemic. However, I do take on board your comments, and I think they're well made.
I wonder if I'd see critical friend in the protocol, because I think it captures it quite well. But we are up against, in any recommendation or request, we are up against national agendas, we're up against NHS England, we're up against a whole series of professional bodies. But we can, if we're not doing that, we're probably not doing our job.
Thank you, Councillor Brooks. Councillor Macro, as Vice Chairman, did you have any comments?
Thank you. It's, the recommendation, I'm slightly puzzled by number 2, because we seem to be recommending something to ourselves. And
I think that's just to recommend that, basically to get a proposer to approve it. I mean, we have had the we have been afforded the access to head of legal to discuss this further as well, which I think most members, apart from Councillor Brooks, attended that call to ask questions of legal as well, which I hope was helpful. I mean, are we still not happy with this protocol? Because at some point we need to, or did Councillor Brooks, did you want to make some suggested amendments? No, okay.
I'm just I was drawing attention to how it might work and what are our outputs, because that's a lot of inputs.
Which we welcome.
Yeah.
Yeah, I mean, that's welcome. We will take that on board. So, yes, Councillor Linden.
Yes, I think we were on general point in terms of our first item. I think we were challenging as well. I mean, I think it's such a wide area. It is challenging. We're still learning a lot as a committee, and it's a continual process with what's going on. We had quite a lot in this agenda, and maybe, you know, we were able to do the early bits within a fair amount of time. So we have to compete there, and I agree with you on competing friends. What I would like to do is propose officers' recommendations, Chairman.
Thank you, Councillor Linden. Can I just make one other point before I look for a seconder on that, is that the task groups, actually, Councillor Brooks, are there to look, to scrutinise and come up with recommendations. So I think that's the way we've been sort of pursuing the recommendations piece. So hopefully that will, when we come on to that as well, we can discuss that in more detail.
Yeah, I make the general point. It wasn't a particular, I was trying to be a critical friend.
Yeah, no, absolutely. And we welcome that. Do I have a seconder for this proposal? Yes, thank you, Councillor Macro. And all in favour? Or thank you. I think that's carried. Conscious of time, moving on to agenda item 10, the task and finish group appointments. So this is to invite members to consider the proposed terms of reference for the healthcare provisions in new developments task group. Has everybody had a chance to have a look at that? And are there any comments or any questions? Anything anybody wants to raise? Yes, Councillor Linden, we've referred it back to manual hands.
Thank you. Yes, 10 and 11 really come together, and I know it's something that we've had a chat about, but and we've had chat with officers, but it is, I think, important that we've only got 5 members of our group, and I know you support widening people outside health scrutiny to be involved, because otherwise it's just going to get unmanageable with the amount of work that we're expected to do, and trying to give that kind of depth with the same people doing the same amounts at the moment. I know we've all got views that we should be a slightly larger committee, but
I think there was the intention, Councillor, to approach other members outside this committee who might be well placed or
I'm willing to do that.
Willing to do it. So the burden is
just too much.
Yes,
pressure,
absolutely. But just moving back to the actual terms of reference, is everybody happy with those? Yeah. Do we need to do any vote on that? Looking towards officers? No. Just agreement. Yeah. Okay, so those are agreed. Okay, thank you. So moving on to item number 11, can I invite Councillor Macro to provide an update on the activities and reporting timescales of the continuing healthcare task and finish group? Thank you.
Thank you, Madam Chairman. Yes, we have met and agreed the terms of reference and work plan, and we're planning to report back to this committee on the 13th of December.
Thank you. Any questions on that? Okay, thank you very much. So moving on to agenda item 11, the work programme. Members are asked to note the work programme and invite, are there any other suggestions or any additional items that members have to add to our work programme? And we will obviously be putting forward any suggestions through our prioritisation tool. Yes, Councillor Linden.
I noticed Councillor Bridgman mentioned about pharmacists. I just put that on our radar, really, whether we wish to do it. I know we've got quite a lot on our plates, to be honest with you.
Yeah, and I noted the Hunter Combe House point that Andrew's nodding at me raised, so we may want to, we will put that one forward as well. Councillor Macro.
judging by family experience, I think perhaps we need to be looking at blood tests and phlebotomy fairly soon, Madam Chairman.
Thank you,
I
Councillor.
mean, there were
Murphy.
times when I think to get one at the West Berks was about waiting list about 3 weeks.
Right. Yeah, we'll take that one on board as well. Okay, there is a form also, just for members of the public watching, there is a form on the website to allow people to nominate topics for Health Scrutiny Committee to consider. So I just wanted to highlight that. So I think that concludes the business for today. So I'd like to thank everyone for attending and for your patience as well. It's been quite a long afternoon. May I ask all panelists to remain in the virtual meeting room and not leave until the Zoom host has confirmed that the meeting is no longer being live streamed. Thank you.